So after the decriminalization of suicide, what we started to see is this conversations about medically assisted and dying. And between 1991 and 2010, the House of Commons and its committees debated around 6 private members' bills, all trying to decriminalize assisted suicide. Now, none of these were passed, but as the political realm was very active in MAID and the questions about MAID, the legal realm was also very active in kind of pushing this issue to the forefront of Canadian society. So in 1993, we see the Rodriguez case. Now, this was someone who was suffering from ALS and was challenging her charter rights that someone should be able to assist her if she wanted to take her own life. Now, while the Supreme Court denied her charter challenge, they stated this is an important issue that Parliament and the Canadian public have to talk about. Now, in 1994, for many of you who are from Saskatchewan, I asked my parents in Winnipeg, they all remember the Latimer case as being a very prominent case in bringing the issue and the ethics around assisted suicide to the forefront. In 2015, we recently saw Kay Carter, who was suffering from a painful degenerate condition. She made arrangements to go through the MAID process in Switzerland, because at the time in Canada it was illegal. Now, after which her daughters, a doctor who was very in support of medically assisted dying, along with the BC Civil Liberties Association, challenged on charter grounds whether that she should have had the option to have a physician-assisted suicide. And in 2015, the Supreme Court said that they were right. It was unconstitutional to prohibit a physician-assisted death with a competent adult who had an illness that was irredeemable medical condition. So after 2015, the Supreme Court sent to Parliament saying this is an issue that you now have to legislate on now that it's unconstitutional. So in Bill C-14, 2016, not that long ago, the Canadian government established the procedure and the safeguards for implementing medically assisted dying, essentially legalizing it in Canada. And Bill C-7, which was last year, they made the amendment to now broaden the access to MAID by getting rid of the requirement that one's death must be reasonable foreseeable. Now, in March 2021, with Bill C-7 passed, it expanded the eligibility of MAID. But now what's happening is that it's opened up the door in terms of one's death did not have to be reasonable foreseeable, to now questions around mental health and whether that would be now per the eligibility criteria. Now, this is saying that the sole underlying condition of mental illness will be allowed, but this is still being in the process of being implemented. It won't come into effect until 2023. So just in general, for some background information on medically assisted dying in Saskatchewan, the Canadian government has posted the 2020 stats on how medically assisted dying in Saskatchewan has been carried out. So in 2020, we see 157 people went through the process. Of those, the majority had cancer or a cardiovascular disease. The average age was 73, and a slight majority were male. Now, the main issues that people brought to why they decided to go through the medically assisted dying process was the loss of the ability to engage in meaningful activities, or the ability to perform the activities of daily life. Now, one of the misconceptions that we noticed when it came around to medically assisted dying is that a lot of people were saying, if they have a MAID process, then you don't have the option for palliative care. Now, what you find with these stats that have been released is that 82% of the people who have gone through the medically assisted dying process were already in a state of palliative care. And it's known that Saskatchewan Health Authority, they work together very closely with the MAID program and palliative care program in order to make sure that the needs that they're delivering meet what the patient needs during that extremely difficult time. So going to talk about just in terms of the safeguards, of the 90% of the requests that have been applied for medically assisted dying in 2020, only 90% continued, and of those, 2.5% actually withdrew at the end. And finally, what we see is the timing of death following the submission of the written request was, for 56%, was less than 10 days. Now, if we kind of quickly just talk about the process of MAID, Serena will take it from here.
Okay, so when you're initially starting to go through the process of MAID, you're originally going to be assessed to see whether or not you meet the eligibility requirements. Eligibility is assessed on an individual basis by either a nurse or physician, and they take into account all relevant circumstances. So the first eligibility requirement is that someone be 18 years of age or older and have decision-making capacity. In this sense, having capacity means that you're able to make healthcare decisions for yourself. The second eligibility requirement is that you are eligible for health services funded by the federal government or a province or territory. This means that if you're only a visitor to Canada, you will not be eligible for MAID. The third requirement is that a request is made for MAID, which is not the result of any sort of outside pressure or undue influence. The fourth requirement is that you will give informed consent to receive MAID, which means that the person has consented to MAID only after receiving all necessary information to make a decision. This includes information about one's medical diagnosis, other forms of available treatment, and other options available to relieve suffering, including palliative care. You must give informed consent both at the time of your request for MAID and immediately before MAID is provided, unless there's a special circumstance, which we will discuss later. It's also important to note that you can withdraw your consent at any time and in any matter. And lastly, the eligibility requirement requires that the person have a grievous and irremediable medical condition, which means that the person must meet the following criteria of having a serious illness, disease, or disability. This does not include mental illness until 2023. The person has to be in an advanced state of decline that cannot be reversed, and the person must be experiencing physical or mental suffering that cannot be relieved under other conditions that they consider acceptable. It's important to note here that you do not have to have a terminal illness to be eligible for medical assistance in dying, but you can also be a non-foreseeable death as well. Now, there are some safeguards in place for those who ask for MAID, and these aim to make sure that the request of the MAID service is done with their own free will, and that they're eligible, and that the decisions are made for themselves, and that they have fully informed consent. And safeguards also help the healthcare providers who carry out MAID make sure that they're doing it in an appropriate manner and in a way that protects individuals from any sort of outside abuse or misuse. So there are a couple differences between the safeguards between someone who has a natural death that's reasonably foreseeable versus not reasonably foreseeable. So I'll start with the former. And the first safeguard is that the request for MAID must be in writing. And this is a written request that will be signed by at least one independent witness. Here, a professional or a personal or healthcare worker can be an independent witness. The request must be made after the person knows that and are informed that they have a grievous and irremediable medical condition. To make sure that this is the way that it is, two independent doctors or nurse practitioners must provide an assessment and confirm that all eligibility requirements are met in this sense. The person must be informed that they can withdraw their request at any time and in any matter, and they have to be given an opportunity to withdraw their consent, as well as expressly confirm their consent immediately prior to receiving MAID. There used to be a 10-day minimum reflection period between the date that the MAID request was accepted versus when MAID actually occurred, but this was recently removed from the legislation, so now there is no reflection period and the person does not have to wait 10 days before receiving MAID. So like I said, there are a couple of differences between the safeguards between someone who has a reasonably foreseeable death versus not. For the non-reasonably foreseeable death, some of the safeguards that are the same is that you have to have that written request signed by a witness, that the person is informed of their condition, and that they have assessments to confirm their eligibility. One difference there is that one of the assessments must be made by an expert in the specific medical condition that the person has. A second difference is that the person must be informed of available and appropriate means to relieve their suffering, which can include things such as counseling services, mental health and disability support services, community services, and palliative care. And then they must also be offered consultations with the professionals who provide those services. Another difference is that the person and practitioners must have discussed reasonable and available means to relieve the person's suffering, and then also agree that the person who is seeking MAID has also seriously considered those other means. Again, immediately before MAID is provided, the practitioner must give the person an opportunity to withdraw their consent and ensure that they give express consent. Another difference is that for the not reasonably foreseeable death, the eligibility assessments must take at least 90 days, but this period can be shortened if the person may lose capacity.
So when someone starts the MAID process, and the patient meets the eligibility requirements, the patient themselves contact the MAID practitioner for the assessment. The assessment takes for about 90 days if the death is not foreseeable, or 0 to 10 days if it is foreseeable. Again, this has to have 2 independent assessments are made, and at the time of arranging the provision of medical assistance in dying, the patient must be competent and able to provide consent for an assisted death to occur. Now, this is something we want to stress, that the patient is free to change their mind at any time. Now, when the day of happens, the MAID providers do their best to accommodate the place and time the patient wants MAID to occur. Talking with individuals who are either part of the program or have gone through the program, it is truly amazing the lengths that the medically assisted dying team go to ensure that the person who is going through the process has their needs met. So, for example, we were giving examples of someone who wanted to have medically assisted dying on their houseboat, or someone in their farm with all their horses, or someone with all their family and friends around. So the program really makes sure that all the needs and requests are met. Now, the drugs that are administered by a MAID provider is through the IV. Canada does not do pill form. And these drugs are administered, and once the drugs are administered, the final process is said to be quick and painless. The patient will drift off to sleep within 3 to 5 minutes. The patient may withdraw consent to MAID at any time prior to the administration of drugs.
So now we're going to talk about a couple of the frequently asked questions that we've seen, addressing some concerns that people may have. One of the main questions that we've seen is whether someone with mental illness as their sole underlying condition is eligible to seek MAID. And the answer is that it is not available at this time. However, in March of 2021, Bill C-7 was passed to allow those who have mental illness as their sole underlying condition to access MAID, but only after putting in adequate safeguards. The exclusion for people with mental illness will remain in effect until March of 2023. And during this time, the Government of Canada and health professional bodies are going to use the time to consider how MAID can be provided safely to those whose only condition is mental illness, and have an expert review considering protocols, guidance, and safeguards, and make those recommendations within a year, reassess, and then will be implemented in 2023. Another common question is whether someone who is in an early stage of dementia or Alzheimer's can request access to MAID when they have reached a later stage of the disease. So the final consent, as mentioned in the safeguard section, there is a safeguard in place to make sure that final consent is given immediately prior to the administration of MAID. But in certain circumstances, they can waive this final consent. And the conditions that must be required in order for that to be allowed is that the person has a natural death that is reasonably foreseeable. And now this is one of the kind of trickier issues that seems to come up, is that someone who might not necessarily have a reasonably foreseeable death wants to still have MAID when they may lose consent. But unfortunately, in the law right now, that is not available. You do have to have a reasonably foreseeable death. And then the other requirements along with that is that the person has been approved to receive MAID, they are eligible for having MAID, and that there is an arrangement in writing with their practitioner that they agree to waive final consent, and that they've set a date for when they would like MAID to be administered. Along with that is the advance consent request for MAID. Again, specifically in Saskatchewan, you have to have a foreseeable death in order to have an advance consent made. And then just some extra information is that you'll be making this decision along with your provincial MAID program and practitioners if you're found eligible, and that this does not act as a will or an advanced healthcare directive. It is only giving your advance consent for MAID specifically. Another question that often comes up is whether someone with intellectual disabilities can access MAID. And the answer to this one is that it depends. It depends on the capacity assessment and whether someone who has an intellectual disability has the capacity or not to make their own healthcare decisions will be made by the assessments of the healthcare providers. The current law states that, again, for MAID, you have to be capable of making decisions regarding your health. A question that often comes up is whether someone can access MAID if they're in rural Saskatchewan, and the answer to that one is yes. There are two main healthcare facilities that answer to MAID requests. There's one in Regina and one in Saskatoon, but they can provide access to MAID anywhere in Saskatchewan. Speaking to people at the Sask Health Authority, as long as it's safe to do so, they have a large network of people who will either travel to the person seeking MAID or send someone out there to make sure that they get the proper care. You do not need a formal referral in order to access MAID, so you don't need to have your doctor or something give you a referral. You personally can contact the provincial MAID program and they will make sure to get you the help and information that you need. In 2020, 71% of MAID administration occurred in urban centers, but almost 30% occurred in rural areas. One of the stickier situations that comes up is whether there's religious concerns with MAID. And this is very dependent on the religion. We've heard stories of faith leaders who are very supportive and who have had MAID themselves. But there are also some religious denominations who do not support MAID. But the overall view that we've seen is that even if they do not necessarily support MAID, they generally will work to make accommodations and provide lots of support for families and individuals going through the process. Another concern that often comes up is whether anyone else can make the decision of whether they get MAID. And the answer is no. The patient is the sole decision maker in deciding whether they want MAID or not. The Saskatchewan Health Authority has a very patient-centered outlook and promotes autonomy of the patient. So they will work with the patient to make sure that all decisions are made by them and that the decision is not overridden by anyone. It can't be overridden by your family or your spouse or your doctor. Consent to MAID can only be made by the patient themselves. And along with that, some people are concerned that once they start the MAID process, can you change your mind and can you back out? And again, the answer is yes. The patient can change their mind and stop the MAID process at any time prior to the actual administration of the drugs. The patient can choose to withdraw their consent to the MAID procedure overall, or they can choose to move their MAID administration to a later date. The main takeaway from this is that MAID is a personal choice by the recipient, and the MAID provider will do everything that they can to make sure that it is as seamless as possible for the patient.
Now, if you're interested in getting further information, Saskatchewan Health Authority has set up a number of 811 to get to their, as a directory to help get to their MAID unit. Be encouraged if you have any questions or you may know someone who wants to learn more about the process. They've been fantastic in making sure that those who are interested in the program or have concerns with the program are met with all the relevant and important information. Now, while that concludes the end of our presentation, like I said earlier, we are in a fantastic place and it's a great opportunity to have Dr. Louie Ford join us. Serena and I have worked with Louie Ford just for a little bit, but we've heard a lot about her through other people that we have talked to. And not being a resident from Saskatchewan myself, all I can say is from the words of others is that Saskatchewan residents are in great hands and are having this program administered by people who truly care that the patient is getting what they need and how they need it. Now, Lillian, we do have some questions, and would you like to ask them yourself, or would you like me to read them out for you? Whatever you would prefer.
What I would like is just to add 2 comments. So they were at the beginning, Serena made a comment that it could be a nurse or a physician making the eligibility assessments. It's actually only a nurse practitioner. So not all nurses are nurse practitioners. So it's only nurse practitioners who can do eligibility assessments, but not all nurses. So it's nurse practitioners and physicians, right? And so, and then the other thing is that of the 2 assessments for people without reasonably foreseeable natural death, it doesn't have to be someone of those 2 that has the expertise in that condition. If neither of the 2 have the expertise, they are required to consult with someone with that position, because most people with expertise would not be one of the approved MAID assessors. So most of us have, we wouldn't all be rheumatologists or cancer specialists or so on. So we have to consult with someone, and then we have to consider that they've had offered the appropriate resources to have that treatment offered, and that often comes with that other person with the expertise. So those 2 important things, but it's a very nice presentation just to hear that. And indeed, I think, knowing I'm very involved in national processes, I think we probably have the most reachable and accessible MAID system in the country. We have a very, very accessible process right now. We're generally a very flexible group of people. We have a wonderful MAID manager, Michelle Fisher, who is kind of the mother hen of the program, and really people, they've actually organized for them to a provider to go into Alberta, because we go to where people are, and Alberta doesn't necessarily do that. And we like to make them not travel, but we go to them. And so I think we have a very good system, and it's very coordinated. Whereas if you're some of the larger provinces, much more, just uncoordinated. The other thing is the provincial program does a lot of the paperwork for us. So they communicate with the federal agencies with us, which is really, really nice. So otherwise, really nice. Challenges now. Okay, so I'm just looking at some of these questions. You want me to just answer them? So, this is really great to hear. Anytime Kyla says, anytime I've had to call or refer, they've been absolutely approachable and fantastic. That's the case. And so now, if I have a terminal illness, do I need to pick a date for MAID, or can my directive be based on the stage? So technically the law says you are supposed to give a date, but people don't often know an exact date. So what people do is give a date ahead, that in Saskatchewan, we say no more than 90 days away from when this is signed. And so that date can then be changed. But what we've said in Saskatchewan is that it can be renewed once without a full assessment, but after that, there has to be another assessment, because this is not supposed to be an advance directive that is like other advance directives, that is sort of nebulous. It could be at any time. It's not. It's for people who are in the close stage of wanting MAID. They're pretty sure it's going to happen within a reasonably foreseeable period, at least within 3 months. So that generally there's a date put on it within which that advance directive would be still legal, and there's a person designated to start that process. So that's a good question. Now, in other words, when I can no longer do this or that, go ahead with MAID. Yes, exactly. So if a person, I've had a few of these now myself, where a person has got horrible cancer or whatever they've had, it's actually been cancer, the cases I've been involved with, and they've signed this advanced care arrangement, which is what it's called in Saskatchewan, and then the person has a large stroke or a tumor bleeds in the brain, and they're right out of it. And so if that's the case, a family member, whoever's designated, can call us, and then we will then get the process going. So I've had 2 people complete coma that had MAID, that would have, before March 2021, would have not had MAID, but they really knew they were at high risk of loss of capacity, and they signed this form and they were able to go ahead with this. So I'm just going to go look at other questions. Extra cost to MAID, no. So the only thing is that that with MAID, if you transfer from some places, so if you're in hospital and you want to go home to have MAID, because as much of MAID happens in people's own homes, and sometimes people want to be there, and you need an ambulance, you might pay for that. The hospital pays if you have to transfer between hospitals if it's a conscientious objection site. So if you have you ask for MAID at St. Paul's and you have to move to RUH for this, they'll pay for that. But other than that, there's no other costs for that. You pay for the funeral the same way you would, of course, anything else. Now, the question Joanne asked, do I need to be able to say, yes, let's go ahead, even if the day in question I'm not able to verbally consent? No. So many of our patients indicate their wish to go ahead. So our ALS patients often can't speak at all. I've had quite a few with ALS now, and one of mine wanted to live as long as possible, did a lot of discussion. She had 3 kids still. All she could do is a grimace, and she could clearly indicate with how she grimaced with yeses or nos that there's a very big difference. So she chose to live as long as possible. She was completely bedbound. So it's an indication. They don't have to actually say it, but we have to know that they're indicating it. I'm going to go back to other questions here. Right, okay, so I think I've mentioned the other stuff. Questions about oral medication. So we are not currently doing oral medications in Saskatchewan. There were at the beginning of the process a few cases where a physician did provide an oral prescription. These would be barbiturates usually. And the problem with it is people go home with them and we don't know who takes them. We also don't know that they will work. And so I'll just make sure that somebody who's doing a little banging in the back could just turn off their microphone there. So what happens is if you take these medications, they're very nauseating and you can throw them up. And so you can be then in a coma and struggling to breathe, but not dead. So there is at least one case I know of where, so this is why rarely this is done at all across the country anymore. And it also takes quite a few hours. So do you want to be lying there for a few hours feeling nauseated and, taking a lot of medications to make you stop throwing it up? And so that's sort of one issue. The other for me is knowing that who else might take those drugs. So if I was to give a prescription, I don't know who takes them. So in Saskatchewan, the College of Physicians and Surgeons has actually said you have to be there. And so even if you prescribe the oral medications, it's not good enough to send them away with you because it's too risky. Could be a granddaughter, grandson, or someone getting access to them. So you have to be available, not necessarily in the same room, but you're in the room to start with, maybe go out, but you have to be accessible. So very few people do oral. There have been a few across the country. There is not a liquid. So the question about Dignitas. So in Switzerland, how it works is that there's an IV set up that a person that has lethal drugs in it, that the person themselves pushes the button to start it. So that it is not legal for someone else to give it to you, but that person gives it to themselves. So they push a button. So we don't do that. We have not got that set up, but there are some places where people are occasionally giving those oral prescriptions still. But Saskatchewan, we might at some point. I don't know that I personally will, because I think the IV is very safe. This is anesthetic drugs. If people fall asleep and they don't wake up, it's very peaceful. It will never fail unless a person lets the IV go interstitial. That means it's not staying in the vein. And if you know what you're doing, you can recognize that. So now, interestingly enough, so one of the biggest problems, so here has option to not administer oral meds deterred some physicians about being on the team. Not that we know of. I think most of us physicians and nurse practitioners worry about giving a prescription and letting someone have those on their own. We would be quite worried about this. Now, the question before that was euthanasia is it a painful death? Euthanasia is not a painful death, actually, and it's a very peaceful death. So if we think about, people worry about that because in the States, for lethal injections, if you use something like potassium, it'd be highly uncomfortable. In Canada, that's not allowed. It's anesthetic drugs. So this is not a painful death, and that is very peaceful. Same stuff people would get for gallbladder surgery. So you fall asleep, you do not wake up. So Florence, yes, I know it's, incompatible with a physician's role. It is no pain with that, but it is a difficult transition to think of ending a life when all of us enter medicine to save lives. And I think This is a struggle for all of us that are involved in this. The balance is seeing people die awful deaths. And, you know, my mother had cancer and it was before me. It was difficult, right? And many of us have seen parents die difficult deaths. So on the balance, if this is probably a peaceful way to go and to decrease suffering. Now, it is even more difficult now with these non-foreseeable deaths because these people are not dying. So many people in the country do not want to be involved with those patients. They will be involved with those that are dying. So we had a conference 2 weeks ago, a national meeting, one of the processes I'm on, and one of the folks in Ottawa was saying that there's hardly anyone of their assessors who's willing to do the non-foreseeable death patients. So just very few will do that. So I'm just going to look at something else. Oral medications. Okay, no way to escape from dementia or Alzheimer's if there's no productive. Well, there is actually. So dementia is though the toughest bit. So dementia is a physical disorder. So we've had a number of people have MAID just for dementia, but there's only a little window in which you can have it because you have to have lost enough capacity to look after yourself. So capability. So you have to be advanced enough that it's really affected your life, but not so bad that you can't consent. So there's this little window where your dementia has progressed enough that what we have to say they're in an advanced state of irreversible decline in capability. So they can't drive anymore, they can't often look after themselves anymore, but they still know enough mentally to clearly ask for MAID. So there's that escape in the short term. Now, there are a number of committees looking at in advanced consent, real advanced consent for dementia, but that's not yet available. It will be eventually because so many people want to have this. It's complicated though, because sometimes when people dement, they eventually forget to have dementia and they can be quite happy and, you know, no longer aware that they have dementia. So, you know, that's one of the challenges that we don't really know. So some of you may have read the paper from the Netherlands case where dementia there is an advanced directive possibility. There was a woman who had this advanced directive, and by the time her family decided to institute this, she had no idea what was happening. She was petrified. She ended up being medicated against her wishes, and there was a huge court process about this. So none of us want to be in a situation of holding someone down who understands nothing and is petrified and doesn't want to do this. So that's why advanced directives are really kind of a challenge. It's more if, you know, I don't know how this will work out exactly. The other challenge, of course, will be mental illness, because many people with mental illness like depression want to die. And many want to die, but most get better with treatment. So we are already hearing a lot of people coming through the emergency department saying they want to have MAID, and they're not legal right now for just mental illness. But how to then adjudicate this, how to make sure this doesn't go so far. This is going to be a real challenge, and there's a lot of work being done on this right now. So a lot of my colleagues across the country are involved in these meetings right now. The Canadian Psychiatric Association, very split on this. On Quebec has just come out to say that they're not in support of MAID for mental illness at all. So that's a challenge. So I've talked a lot here too. So are there other questions? I can see the people who've put them up in the chat. Are there any people who just want to ask something? And because if you unmute your microphone, you can ask questions.
Lillian, there was one question at the beginning of the chat, which was actually asked of Serena and Sasha during the presentation, and it was asking about explaining the 2.5% of people on a slide. And the writer asked, can you explain that a bit better? Is it only 2.5% of people that went through with MAID? And I think it was the other way around. Could one of the three of you perhaps explain that part? It had to do with withdrawing.
Of that statistic, Dr. Sword, please correct me if I'm a little off base here, but my understanding of the statistic that was published by Saskatchewan Health Authority is that of the 157 people who went through the MAID process, those who applied to the MAID process, 90% of them went through the MAID process. The MAID process was delivered. Now, of the remaining 10%, 2.5% withdrew their request for MAID and it was administered. The other 7.5% either changed their mind or they passed away and focused on palliative care. That's my understanding of the statistic.
Good.
Yes, many people actually have a lot of relief when they're approved for MAID, and then they go ahead with the natural dying process. This is very, very common. And so it's not that they're actually taking away the request, it's that they know it's there and they are happy that it's there, but they just keep going, and then they often die naturally. Now, my own stats that I've kept, so we all have different stats. I probably have slightly different stats than other people because so many people have that I see are complex and that might not be as eligible as others. But my experience is that a lot of people, once they have the ability for MAID, actually don't necessarily go on with it. They don't withdraw it. They just don't necessarily go on. They die naturally. So that's my experience. The other is it's complicated to know because sometimes somebody applies in that same year and they may not actually have MAID for another year or 2 years. I've had people over 2 years that dying horrible cancer. We all thought they were dying quickly and they've lived another 2 years. So they may not show up as having had MAID that year, but they may eventually have MAID. So unless you follow everyone through to their actual death, you can't say how long it takes or how many people will actually have MAID because you sort of have to wait it out.
Good.
But it was a bit confusing. It did look like only a small percentage went, but very few people formally take it away. Will say, no, I don't want this anymore. Very, very rare. So, okay, so I'm reading. So, Florence, so Euthanasia Prevention Coalition has a document outlining the pain of euthanasia. So that's actually not correct. So there is a lot of misinformation out there about MAID, right? So there is not. It is not true. So the misinformation would be similar to a lot of the misinformation that's out there about vaccines, and unfortunately, how this gets up there is usually by people who really don't know what the process is like, and so it isn't painful the way it's done in Canada. Now, if you did it with potassium or something, it would be highly painful. So it is not painful. Now, the second bit though, a dangerous slope. So many of us do worry about this, and I totally get this because we're now having people without reasonably foreseeable natural death that are in their 20s, that have cerebral palsy, that have all kinds of conditions that, they could live a long time. So it is a bit of a slippery slope. And many of us worry about this, that, we kind of got to accept this because people were dying, and we knew that overall people have often done this under the table, so that somebody's dying a horrible death. We've given people, or doctors in the days gone by, have given medications, higher doses to stop suffering. But what's happening now with people without reasonably foreseeable death, that's much, much more difficult. And that does look like a bit of a slippery slope. And we have to be really, really careful with this one. We're getting increased numbers of people asking for that reason, and it's very complex because the main goal then becomes finding other solutions for those people. And I've had, it's many hours of work finding other solutions because most of us don't want people to die unless they really are dying. So, so I know this is really hard, Florence. I can see you're struggling with this. I totally get it. It is very worrying for those of us who are a generation away from Europe, where there were people in the death camps who were killed against their wishes. We worry that it's going to go too far. I totally get it. And that's why it needs to be all above board. We audit everything. It has to all be documented. We follow processes. We have signatures. We have 2 of us who do things. We have to be very careful with this. Absolutely. And so then Joanne, so mental illness, that is a big, big issue. She's no longer productive. She has no quality of life. So yes, so we have a lot of ableism in our society. We think people are not worthwhile if they can't produce, they're not productive. And this affects a lot of our patients with disabilities. My PhD was in disabilities, and I'm very involved with people who have intellectual disabilities, and they have a lot of stigma in their lives already. And that's always been a risk, that people feel they're not worthwhile, and that our societal lack of supports makes people ask for this. So this is why this has become so complex, because we work so very hard to find those solutions to those people. So the MAID program, the very wonderful thing about how this is set up in Saskatchewan is that it's part of the 811 health line. So when somebody applies who's clearly not really eligible, they have other solutions that have not been looked at. They are closely connected with all sorts of other people that are working in all the other areas. They can access resources throughout the entire province. And that's not the case in the whole country. So I think Saskatchewan has got a very, very good system, because we then are really working hard to do this. So patient I saw earlier this week, I probably spent 8 hours finding other resources. I finally found some other resources for this person for whom MAID is clearly not the answer. It's really intensive, and that's what we need to be doing. So mental illness, big issue. So a lot of people don't have good access to mental health supports throughout the province. Big issue, right? So we have to make sure they have that access. And so how do we do that? Well, we have to find a way of making that happen. Yeah, and Florence says, yes, there are a huge number, there's a big increase in people doing this. And so it's good and bad. So it's good, we're decreasing suffering, but we have to always be attuned to the fact that this is a process that's irreversible. We have to be very careful that people have really carefully looked through their options, that people are not accessing this when they're highly frustrated, that they're in a mild delirium, they've just come in with a pneumonia where they're not thinking very clearly, because that's when often people say, I can't live anymore. We have to be very, very careful how this happens. And so I'm involved with a national group that is looking at developing curricula for assessment of MAID, because people across the country are doing MAID assessments that may not have always this background that I have, where a lot of my patients in geriatric psychiatry say they want to die. And when they're very stressed, they come in with illness. And then when the illness is treated, they don't want to die. So we're developing curricula so that we can have training programs for our assessors that will better understand that. And it's very important.
Lillian, I'd like to thank you very much for your diligence in this. It's very admirable, and I feel safer because there are these that you're giving all these options to people. But the bottom line is, I think many of us looking at our ages and stuff, we want to have that choice, and it's our bodies, and so I think it's if people don't want to access the MAID, then that's their choice. And so I thank you for all the time and effort you put into it, and your team, and this idea of doing better training and stuff, more as far as how to assess, is just great. So thank you very much.
Yes, and I would like to thank, on behalf of the Saskatoon Council on Aging, I would like to thank Sasha and Serena for the very informative presentation that you have given today, and also for being such wonderful people to work with during the developing resources for SCOA. And I also want to thank Dr. Thorpe. Thank you so much, Tricia. That was a wonderful thank you. I agree with you. We really appreciate your generosity for all the time that you spent with and the assistance that you gave to Sasha and to Serena and to us today. I agree with what Tricia had said. I'm just so glad. I always have been. I remember talking with you about this earlier, that you wanted to make sure that it could be done so badly, and you wanted to make sure that it was done right. And I think that all of us here today sense your sensitivity, and you're working on trying to help people who clearly, even people who are not eligible for the program, maybe spend 8 hours trying to get them the resources they need. I think and you're helping develop a national curriculum. I agree with you, Tricia. I think we all feel safer with Lillian involved in this kind of thing. Thank you so much, Lillian.
Elliot,
And
can I
thanks.
just answer this one
Yes,
question
certainly.
here? First,
Yes.
Florence mentioned. So Florence, again, she said, will the right to kill become the duty to die? So this is actually, it's interesting. I have that in a slide where I talk about this, because a number of years ago, there was a politician in Colorado that talked about the people's duty to die and get out of the way. And there's a book written about this as well. So this is always the concern, that people should not ever get to that point where it's a duty to die. This is such an important thing to have mentioned. And this is why it's so good to reflect a whole range of different opinions, because people like Florence, it's very important to speak out in those ways, because having those ideas out there makes us all stay in the middle, in the healthy middle, so that we never get to that point where we feel there's a duty to die, because we should not. That is on one of my presentations. And so thank you for mentioning that, Florence.
Yes, thank you. And thank you, all of you, for coming. With the webinar will be posted on the SCOA website in a few days' time. And if you want to see it, you Google www.scoa, that's SCOA.ca, and you'll be able to review the webinar and this discussion as well. So thank you, all of you, for coming, and thank you to Cynthia Johnson for all the technical arrangements. That we would not have been able to do this without her. Thank you so much, Cynthia. Thanks, everybody. And